Welcome. Thank you all for joining us today for our Advocacy Grand Rounds. Before we get started, I wanted to take a quick minute to invite you to officially join Doctors for America. Being a DFA member today means taking the important and simple step of selecting a membership level and paying your annual membership dues to support our organization's sustainability and incredible programs like this Advocacy Grand Round series. There are 4 different levels to choose from, and a DFA member will put the link in the chat now if you're interested in exploring those. We will be live streaming to Facebook Live and making a recording of all materials that will be available afterwards as well today. A few quick round rules for this educational session. 1, there's no such thing as a stupid question. And 2, speaking of questions, please remember to use the Q&A feature, and we will address your questions during the second half of our session. And also look out for comments in the chat. We'll be sharing helpful links during the session. Now I'll get to introducing our speakers, which we are thrilled to welcome, Dr. Anna Maria South and Dr. Brandon Kasberg. Dr. Anna Maria South completed medical school at the Boonshack School of Medicine and residency in internal medicine at the University of Kentucky. She's an associate professor of medicine at the UK College of Medicine in the Department of Internal Medicine in the Division of Hospital Medicine. She is a certified internal medicine doctor and addiction medicine physician. She works as a hospitalist in addiction medicine with an interest in vulnerable patient populations with substance use disorder. Secondly, we have Brandon Kasberg, PharmD, who completed pharmacy school at the Raby College of Pharmacy at Ohio Northern University, followed by a pharmacy residency in pain management and palliative care. He is a clinical pharmacy specialist at the UK Healthcare, specializing in pain management, along with being an assistant adjunct professor in the University of Kentucky College of Pharmacy. His clinical interests include pain management in the setting of substance use disorder and/or long-term opioid therapy. So unfortunately, patients with a history of addiction and substance use are often mistreated in medicine due to implicit and explicit biases. Specifically, patients coming in with acute pain are often undertreated when they have a history or have an active substance use disorder. We plan to explore how to provide evidence-based, patient-centered care in these settings. I'll pass it off to Dr. South to begin our session.
All right. So today we're going to talk about pain management in patients with opioid use disorder. And I'm first going to talk about a patient-centered approach to pain management in patients with opioid use disorder. And we're going to talk about how to apply pain management strategies to different types of patients, different types of pain in patients with opioid use disorder. And overall just talk about how we can care for these often stigmatized and vulnerable patient populations. So just to set the stage, there are 3 FDA-approved medications for treatment of opioid use disorder. We have methadone, buprenorphine, and naltrexone. All 3 of those have a different mechanism of action. And buprenorphine and methadone are mortality-reducing medications. So I will talk about that a lot. And I do want to highlight that these are extremely effective medications. The number needed to treat for buprenorphine in the outpatient setting is actually 2 to 4 patients. And sometimes you will hear people talk about treatment without medication for opioid use disorder. So I'll use the abbreviation MOUD for that, for medication for opioid use disorder. Sometimes you call that abstinence-only treatment. And the retention and care for that is actually extremely low, 10 to 15%, whereas the retention in care for patients who are on medication for opioid use disorder is between 50 and 80%. So whenever I talk to my patients and they are not sure if they should do medication or not, I talk to them about that it is mortality reducing, that it reduces their cravings, and methadone and buprenorphine also treat their withdrawal, and that it increases their retention and care. So it's a win-win situation all around. And this is kind of one of my favorite slides that I use whenever I talk about medication for opioid use disorder, because I think it just really visualizes how important these medications are. Somebody that has an untreated opioid use disorder has a mortality that's about 6 times greater than the general population or people without an opioid use disorder. When this person is started on medication for opioid use disorder with either methadone or buprenorphine, that mortality goes from 6 times the general population to about 1.8 times the general population. So that's an over 50% mortality reduction. And I, as an internist, prescribe a lot of medication, right, for like infections, high blood pressure, diabetes, all of those chronic medical diseases, just like opioid use disorder. And I struggle to find other medications that have such a significant mortality reduction. However, due to stigma and biases, less than 10% of people who could benefit from being on medication are currently on medication. And I think about that the same as I think about diabetes. Let's think if we're talking about people with diabetes and we said less than 10% of people who would benefit from being on insulin are currently on insulin. I think everyone in this country would be outraged. However, for opioid use disorder, due to stigma, we've just kind of taken this as a given fact. And that is one of the reasons why the mortality is still so high in the opioid crisis. So I appreciate all of you coming here to this webinar to learn more about this so that we can actively do things against the mortality of opioid use disorder. Buprenorphine, I've mentioned it before, it's a mortality reducing treatment for opioid use disorder. And it's a partial mu receptor agonist that has a high affinity for the mu receptor and slowly dissociates from the mu receptor. And I think Dr. Kasberg will talk about this a little bit more in his part. The really nice thing that we know about buprenorphine is that it has a ceiling effect when it comes to respiratory suppression or the suppression of the respiratory drive. So if somebody takes too many full agonist opiates such as oxycodone, heroin, fentanyl, or even methadone, eventually the respiratory drive in the brain will be suppressed to zero. The person will stop breathing and die from an overdose. This is not true for buprenorphine, but usually the respiratory suppression still happens, but it levels out about between 9 to 12 breaths per minute. And I feel very comfortable having my patient breathe 12 times a minute. And what I do want to emphasize is that ceiling effect is not the case really for analgesia. There's no studies that show that, at a certain level, all of a sudden, we've maxed out the analgesic properties. So it's a good medication that we can use for pain treatment as well. And there is an extended release version. There's 2 extended release versions. The brand names that you guys might have heard are Sublocade or Brixadi. And they have more consistent blood levels than the sublingual product that a lot of patients are on. General principles that I want to remind you for everyone that has opioid use disorder. These are patients that are opioid tolerant. And I put this here twice because I think this is the most important take-home point. These are patients that are used to taking opiates, and in order to treat the pain, you need to first overcome that opioid deficit that they have. If they're always taking opiates, all of a sudden they are withdrawing from an opiate. Now they have a deficit that you need to overcome first before you can start the pain treatment. This is a very simplified way of looking at it. But therefore, higher doses may be needed, and sometimes 2 to 3 times the regular dose. And as a consultant on the addiction medicine team in an inpatient service, I get so many consults for pain management. And I'll open the chart and I see, this is somebody that in the HPI, the doctor wrote, uses fentanyl via injection route 5 times a day. And then I look what they ordered for pain management, and they are only on oxycodone 5 milligram Q8 hours. That is never going to even treat the opioid deficit, right? This patient is probably going to be in withdrawal on the oxycodone, and we're not going to make headway in pain management. So therefore, the dosing needs to be adequate to treat both withdrawal and treat pain. And I really always tell my residents, everything is fair game, right? You can use oral agents, you can use intravenous agents, you can use extended release agents or short-acting agents. And a lot of times we use a combination of all of them. And it is important to remember that when patients are hospitalized, they can lose their tolerance to opiates fairly quickly, and any loss of tolerance puts them at a risk of an overdose after release from the hospital. And the loss of tolerance can really happen in a few days. So this is not only for your patients that are in the hospital for several weeks for antibiotics for osteomyelitis, even somebody that's just there for 3 days for a cellulitis from injection use can lose tolerance during that time. And these are patients that have been stigmatized by the healthcare system, so they might be apprehensive when they come into you first. So reassure them that we will treat both their pain and their withdrawal, that we want to take care of them, that we don't want to see them suffer. And involve the patients to make patient-centered decisions and practice patient-centered care. Depending on what they've got going on, like if it's, teeth are an easy example, if it's tooth pain, consider a local block if you can, and then never ever forget about your multimodal pain management. So NSAIDs, I should say acetaminophen instead of Tylenol, lidocaine patches, things like that. And like I said, you won't believe how often I get consulted for pain management, and all that's ordered is oxycodone 5 milligram. So unless there's medical contraindications, I always recommend scheduled Tylenol as it works on different receptors. And then I always recommend NSAIDs as well, unless there's medical contraindications. And I found that especially NSAIDs are super helpful for things like, kidney stones, bone pain from infection, cancer, things like that. So always making sure that patients have a multimodal pain regimen available, and then also educate your patients that, they can use it in addition to Tylenol and in addition to NSAIDs because they work on different receptors. So sometimes they think, that we are giving them acetaminophen to try to replace the opiates, and that is not the case. We should still give them opioids. And then we also use non-pharmacologic pain management. So we in our hospital have music therapy, and it's wonderful when they come and do processing of pain and painful stimuli with our patients through music. We have art therapy as well, physical therapy, there's service animals, acupuncture. We have narrative therapy where patients can do verbal processing. And then, things like heat and ice packs, massage therapy. We intermittently have massage therapy. And our patients love getting a nice massage to help with their pain while they're hospitalized. So these are things that you can all do in addition to traditional pain management. And for some of them, the data is not as robust as for pharmacologic pain management because not as much has been invested in studies. But I think even if you don't necessarily believe in the pain management strategy of it, just the fact that people get distracted from their pain is really helpful as well. So if you have a patient that is on buprenorphine while they're in the hospital, there's different ways to treat the pain. Number one, you always want to continue the buprenorphine if the patient is willing to continue it. Because if you stop the buprenorphine, you create that opioid deficit that you then have to overcome. So you don't want to do that. So continue the buprenorphine. You can split the dose to capitalize on that analgesic effect. And the analgesic effect lasts about 4 to 6 hours. So I always talk to my patients about that because some of them hate the taste so much that they only want to take it once a day. And I think that's okay. But if they're willing, you can give it 3 times a day, 4 times a day. Just take their home dose and split it. Remember to add the non-opioid options like acetaminophen and NSAIDs or music therapy, the local block. And then always remember to talk to your patients. This is an area where they have a lot of anxiety around because a lot of times pain is one of the reasons why they use opioids. And it's also one of the reasons why they've been stigmatized. So involve your patients in these decisions. If you have a patient on buprenorphine that has a moderate pain procedure, so I think of this, for example, an epidural abscess or osteomyelitis, always continue the buprenorphine. Remember, you can split the dose. Another thing you can also do is you can increase the buprenorphine temporarily to get more pain management. And then you can also add opioids on top of the buprenorphine. And sometimes our patients are scared about that because they've experienced precipitated withdrawal before in the outpatient setting, a lot of times on the street when they've tried buprenorphine from an illicit source. And what I explain to my patients is the reason that happened is because you had your mu receptor that was fully saturated by a full agonist, such as fentanyl, and then you brought the buprenorphine in, which has a tighter affinity to the mu receptor that kicked off the fentanyl from the mu receptor, and then it bound to it very tightly, but since it's only a partial agonist, the remainder of the mu receptor was still open and screaming, saying, I need more opiates. However, if you have your mu receptor and you have the buprenorphine bound there first initially, you have parts of the receptor open that are not screaming because they're used to the buprenorphine, and you can add other full agonists on top of it. So the order really matters. So if the buprenorphine is there first, you can add full agonists on top of it. Just remember these are opiate tolerant patients, as I mentioned before, so they might need higher doses of full agonists. And since I see a lot of my patients in the hospital, I have the benefit of I can just try a dose and then I can see them again in an hour or two and see if it worked or if we need to increase the dose further. And as I said before, always talk to your patients, involve them in all of these decisions. The extended release buprenorphine, this can be administered as this is a long-acting agent. The two brands that you guys probably see most often are Sublocade or Brixadi. It's a sub-Q depot shot. The first 3 doses are always given into the abdomen, but there's other areas where you can give it to, like the arm, the thigh, the buttocks, things like that. It lasts about 4 to 6 weeks, depending on the formulation. And the most common formulations are equivalent to 16 milligrams of sublingual buprenorphine or higher. There's now also lower doses available. There also was Probufene. These were the rods that people had in their arms. This has been removed from the US market, not because it was unsafe, but just because of cost. There was too few patients on it. But sometimes you might find patients that talk about that they've been on that. So if you have a patient that is on the extended release buprenorphine, treat it as if they were on the sublingual buprenorphine. Obviously, it's in there, so you are basically continuing it. You don't have a choice. But then remember to add opiate tolerant dosing of full agonists on top of it if you need to for pain management. For methadone, the important thing is when you pull your state's PDMP, methadone will not show up on there because it's given directly at the methadone clinic versus being dispensed through pharmacy. So therefore, it does not show up on the PDMP. You can always call the methadone clinic to verify what dose the patient is on and when they last dosed. A lot of times you need to call the clinic early in the mornings because a lot of them dose early in the mornings, but the clinic should have a representative that you can call at all times to do a dose verification. You can always get a urine drug screen too to confirm that the methadone is present in the patient if for whatever reason you cannot confirm with a clinic. If since this is a full mu receptor agonist, if you have a patient that is in any respiratory compromise and you're not sure about the dose, you can always start a lower dose. And then I just put this here. If a patient comes in and is already intubated and they're on methadone outpatient, continue it while they're intubated because we get a lot of times consults from the ICU of patients that are intubated and they say, we can't control their pain, we can't sedate them, and they're holding their methadone. So if they continue the methadone and then all of a sudden the drips that they have them on for sedation work a lot better. If you have a patient that comes in and has some sort of pain and is on methadone, remember to continue the same dose of methadone as they are on outpatient, as long as it's medically safe for the patient from like a respiratory standpoint. And you can also here consider to split the dose, kind of similar to buprenorphine. The analgesic effect lasts about 8 hours. So you can have your patients take it 8 hours. So if they're on 120, you could split it by 3 and have them take 40 milligram every 8 hours. Just remember to talk to your patients about it. They are very sensitive to you, adjusting their methadone dose. They're scared they're not going to get enough. So if all of a sudden you only give, the nurse shows up with 40 instead of 120, they might be like, why am I not getting my full dose methadone? So just talk to them so they know that it's for pain management to split it. We do typically not increase methadone for treatment of acute pain. So this is where it's different than buprenorphine, but because of the respiratory suppression risk and the long half-life, that's about 72 hours, that can be QTC prolonging. So instead, I would recommend to add short-acting opioids, such as, for example, oxycodone, on top of methadone, because you are monitoring them. You can see if there's any risk for respiratory compromise, and you can see to what dose works. So try a dose and see if that helps with the pain. And then monitor for sedation. And once again, these are patients that are not opioid naive. So they might need higher doses, but now, you have two full agonists, methadone and whatever other opioid you choose. So just monitor them for sedation. And I put here in the hospital, I always get an EKG just because of the QTC prolonging effect that methadone can have. And a lot of times patients in the hospital also get other QTC prolonging medications that they might not be taking in the outpatient setting, such as some ondansetron or nausea medications, some of the antibiotics are QTC prolonging, especially antifungals, things like that. Naltrexone is a full mu antagonist or blocker. This can be taken by mouth, but for people with opioid use disorder, it's usually the injection, and it should be an IM injection, which is known under the brand name of Vivitrol. The challenge is to initiate patients on naltrexone because they need to be opioid free for about 7 to 10 days. And sometimes some insurance companies require you to confirm that with a daily urine drug screen. It is FDA approved, but overall the data is a lot weaker and it does not treat withdrawal and it does not have that mortality reducing effect that I mentioned for buprenorphine and methadone. If you have a patient that is on naltrexone, since it's an antagonist, it makes pain management a lot more challenging. If they're on oral naltrexone, ideally the patient stops their naltrexone about 2 to 3 days before a procedure, and then you need to add opiates at opioid-tolerant doses for the patient. If they are on the IM injection, that gets administered every 4 weeks. So ideally, if it's a planned procedure, you wait for 4 weeks after the last administration. And it's very challenging to overcome that mu receptor blockade, especially in the first 14 days. And this is where you really often need a multidisciplinary approach where they need to maybe be on a patient-controlled drip where they can push like a PCA and where they need high affinity mu receptor full agonists such as hydromorphone and also maybe some ketamine. I already said that. So, am I causing any harm if I give my patients who have an opioid use disorder any opioids? And the answer is actually no. Because if you force your patients to withdraw from opioids while they're admitted to the hospital, that significantly increases their risk of a relapse or return to use. And if a patient has a return to use after a prolonged period of abstinence or not using, they are at really, really high risk for overdose because they've lost their tolerance and they're at really high risk of dying. And it's really important to say that withholding opioids does not cure their opioid addiction. They already have the disease. And by not giving them opioids, you're not helping them and you're not making the underlying opioid use disorder any better. So if you have a patient that is already on full agonists, let's say you are in the hospital, you have a patient that's admitted for endocarditis, osteomyelitis, is on oxycodone already, but wants to start buprenorphine, but does not want to go through the withdrawal period, you can do a few things. So if they want to start methadone, it's a full agonist, and you can just start it on top of whatever other full agonist they are on. Just monitor them for sedation. For naltrexone, as I mentioned, you need that 7-day washout period. So that's why it's really hard in the hospital to start patients on naltrexone because a lot of them are there with conditions that are painful. And then buprenorphine, this is where you can do the microdosing or cross titration approach. And this is outlined here in this little picture. So you can see in the top line here, if you replace all the full agonists, which is the like 5-piece shape here, with a little, I always call it a little Reese cup, like the partial agonist, if you replace it too quickly, then the patient goes into precipitated withdrawal. So that's withdrawal that comes on all of a sudden, and patients go from feeling fine to feeling extremely miserable. However, if you replace them slowly, one by one, with small, I call it baby doses, and it takes a few days, over the course of a few days, the patient doesn't feel that withdrawal feeling. And actually, a lot of times when I ask my patients, how are you feeling on your day one of the microdosing? They say, I don't feel anything at all. Good. That's how it's supposed to be. And this is an example. This is our 7-day protocol that we use at the University of Kentucky. So we have the buccal, I never know how to say it, formulation of the buprenorphine available. And it starts at 150 microgram twice a day for 1 day. So I tell my patients, if you had a 2 milligram strip and you cut it in half, then you would be at 1 milligram. You cut it in half, then you would be at a half a milligram. You cut it in half again, you'll be at 0.25, and you cut it again. That's how small it is. And the most important thing is you need to continue the patient's full agonists that they are on, because that small baby dose of buprenorphine is not going to be enough to completely treat the opioid deficit that the patient is experiencing. And then here I outlined the steps of how we increase the buprenorphine every day while continuing the full agonists. And then most importantly, once you have the patient on a therapeutic dose of buprenorphine, so 12 milligram or higher, you can discontinue the full agonists without them going into withdrawal. It might still be appropriate to continue full agonists if they're still having pain. But if the pain aspect of the hospitalization has resolved, you can just stop them without the patient experiencing any withdrawal. This is another protocol that we use that is a little bit quicker, that goes over a 3-day protocol. So this is just available for your reference. It's the same principle, just showing you that you can do it quicker. And then if you do it outpatient, you would just give the patients the buprenorphine, either the tabs or the strips, with instructions on how to cut it. And just remember, you could not legally prescribe the full agonists. So the patients would probably continue using whatever they're using on the street while you're microdosing them. So just to remember that, so that you can still educate them about naloxone, never use alone, things like that, while they're undergoing the microdosing outpatient. I have a few cases. Should I maybe do these later so that Dr. Kasberg has a chance to present, or do you want me to go through them now?
I think you're okay to go through them if you want to go through at least one or two of them.
Okay. Thank you, Dr. Kasberg. All right, so the first case was acute pain after a knee replacement. So this is a 52-year-old male with severe opioid use disorder. He's in sustained remission, and he's on extended-release buprenorphine for 2 years. And he has a planned knee replacement, and he's actually on the 100 milligram dose of the extended-release buprenorphine that he got 27 days before surgery. And the patient really, during his knee replacement, was okay to receive full agonists, but his preference was he did not want to be discharged on full agonists. So that was his goal going into this planned surgery that we knew we wanted to honor and practice patient-centered care. So he was able to get a nerve block after his knee replacement, and then he received NSAIDs for pain management as well as acetaminophen. And while he was inpatient, he actually received fairly low-dose oxycodone, 5 to 10 milligram every 4 hours as needed. And at the time of discharge then, we discharged him with scheduled NSAIDs and acetaminophen, as well as additional sublingual buprenorphine on top of the extended release that he had already gotten 27 days prior to his surgery. And we gave him instructions on how to cut the films and how to take the extra doses to capitalize the analgesic effect of the buprenorphine. And he then returned to clinic and got an extended release buprenorphine injection again and remained in remission from his opioid use disorder. So he was very proud to go through this painful surgery on his own terms, how he wanted, with a short course of low dose inpatient full agonists, but none at discharge, and did buprenorphine instead at the time of discharge. The second case is a lot more unplanned and more painful. So this was a young female with severe opioid use disorder that was in remission on extended release buprenorphine for 10 months. She had gotten her extended release buprenorphine outpatient 12 days before the event happened, and then she presented for an acute limb ischemia from an embolic event that she unfortunately had chronic fungal endocarditis that she was getting treatment for, and part of that mass had dislodged and caused an ischemic leg. So as you can imagine, an ischemic leg was extremely painful, and this was also unplanned, so we couldn't really make a plan for pain management prior to her presentation. So she needed to be put on a inpatient on a PCA, so a pump where she could control push how much she needed. And she was put on this with high affinity full opioid agonists. So we chose hydromorphone. And she had a bolus dose as well as that she could at a base as well, basal bolus. And she went to the OR. She had her clot removed, but she also had compartment syndrome, so she needed intervention for that. It was very painful all around. And on post-op day 4, she told us that she felt like she was ready to transition off her PCA and try with oral full agonists as well as some IV for pain through. So we, in a patient-centered approach, chose oxycodone and morphine for her. And then since all of this was due to her chronic endocarditis, she actually chose to undergo a heart valve replacement. So a second very painful procedure. And once again, she was on a PCA that was titrated to her needs. And on after her sternotomy on post-op day 8, she transitioned off the PCA, and at that time she had a lot lower PCA requirements compared to post-op day 4 after her ischemic leg, and was actually transitioned to lower doses of oxycodone. And at discharge, she did not want to be discharged on any full agonists, and she did receive her extended release buprenorphine injection at that time, and she remained in remission from her opioid use disorder. So I think that's just really important to highlight that she had this very stressful event, 2 big surgeries back to back, and she was able to remain in remission and be discharged without full agonists. She was very proud of that. And then my last case is a patient that had chronic pain from malignancy. She was in early remission of her opioid use disorder, and she was on extended release buprenorphine 300 milligram that had been administered 14 days prior to presentation. And she was diagnosed with a metastatic cancer at that time, and she did not want to receive full agonists initially. So what we tried to do is give her sublingual buprenorphine on top of the extended release buprenorphine that she had received. And we gave her 8 milligrams 3 times a day, and then tried actually 16 milligram twice a day. So for a total of 32 milligrams per day. And unfortunately, even with that, despite adding things like acetaminophen or NSAIDs, her pain was not controlled adequately. So we added full opioids on top of it. And initially she got it every 6 hours. And then once her initial pain, kind of like we got over that initial hump, she wanted to decrease it to twice a day. And then she was achieved adequate pain control on oxycodone and high dose sublingual buprenorphine. And for her oxycodone, she actually was only on 10 milligram twice a day. So I would say that's very low dose oxycodone for somebody that has an opioid tolerance. And she sadly passed away in hospice, but was able to have her pain well managed. So with that, I just kind of want to highlight that these show 3 different patients with 3 different types of pain and 3 different types of events that happened, that highlight how important it is to individualize the approach to pain management and how important it is to get our patients involved so they can tell us what their goals are so we can honor them. And since buprenorphine has a wide variability in pharmacokinetics, it's also important to individualize the dosing. So you saw here, we used different doses for the patient that had the knee replacement compared to the patient that had the metastatic cancer. And if you have the transmucosal formulation, so the sublingual or the buccal formulation, the half-life is about 24 to 42 hours. But for the extended release, it's 43 to 60 days. So for our second patient, you saw that she got her injection 43 days after the last injection. So it was still within that window, and she didn't go into withdrawal because it was still within that time of the half-life. And there's actually case reports out there for patients that have received extended release buprenorphine and then didn't receive any more due to pregnancy, that still had buprenorphine in their urine at 6 months. So that half-life and that tail might be even longer. So it is possible to manage pain for patients with opioid use disorder effectively, even if they're on buprenorphine. Sometimes people feel like they can't manage their pain. We need an individualized, patient-involved approach. The doses need to be titrated to effect, and we might need higher potency, and doses of full agonists may be needed. This is where we really need a multidisciplinary team, so it's really helpful to have a pharmacist or palliative care physician or anesthesia involved. And there is some barriers, including the lack of knowledge of buprenorphine formulation and clinician bias. And with that, since we're talking about multidisciplinary team, I will hand it over to Dr. Kasberg. This is my email, and then this is the paper where we had the cases that I discussed. And I will stop my share.
All right. And I believe my slide should be visible right now. And thank you for the great presentation, Dr. South. As a pain management clinical pharmacist, I most frequently interact with some of these patients with OUD or on chronic long-term opioid therapy during their episodes of acute pain. So I'm hoping to provide you guys with just some tips and tricks that you can take into your practice. A few objectives. First of all, I want to really discuss the role of oral morphine equivalents, morphine milligram equivalents, MEDD, and what these all mean and how this can help with working through patient cases and determining what doses might be required in an acute pain period. I also want to go through and differentiate some of the properties of our medications for opioid use disorder. I know Dr. South did a great job of this, but maybe adding a few pearls or at least cementing some of those concepts into you all. And then lastly, we'll discuss some considerations for managing acute pain in the setting of opioid use disorder or patients taking medication for opioid use disorder. So Dr. South discussed a few examples of bias, and I think there's some importance to using proper terminology when discussing with patients, with your medical teams, and even when you're documenting in the electronic health record. So we have some terms, and really we have this opium poppy. There's a bunch of substances that come from that, and the natural substances are called opiates. So we have things like morphine and codeine, which are actually, fully from that plant, and they're called opiates. And we have things that are called narcotics. You might hear this term used loosely, but this is really a legal term for any substance, including opioids, meth, PCP, things like that. It's more of a broad term for substances that may result in legal action. Thus, we find ourselves at opioid, which I think is the best umbrella term when talking to patients, when documenting in the EHR. This is an umbrella term that includes both our natural opiates, so things like morphine and codeine, but also some of our synthetic opioids, such as fentanyl and methadone, and our semi-synthetics like oxycodone and hydromorphone. So just a tidbit that can go a long way with your rapport and reducing bias in some of our patients. I think it's crucial to understand some of the dose response and opioid activity at that mu opioid receptor when we're talking about these medications. First, we have these full agonists, so things like oxycodone, methadone, hydromorphone, fentanyl, and they provide that linear dose response up until our limiting factor, which is opioid-induced respiratory depression. We see partial agonism, or our partial agonist curve here kind of plateaus off, and that's really where that ceiling effect comes into place. Now, with low dose in our pain products for buprenorphine like IV Buprenex, our Belbuca, Butrans Pax, those are really microgram dosed products that have that linear dose response. It's really when you see 12 to 16 milligrams of buprenorphine where you get this plateau or this ceiling effect where there's a lower risk of that respiratory depression. I wanted to provide some common dosing for some of our opioids. There's no need to read through all of this, but I think it could be a good reference for you all because understanding, first off, dosing for opioid naive patients will help us address the needs of our patients who require increased dosages of opioids. You'll see in some of the clinical notes, some pearls. I want to highlight a few. You'll see that most of our long-acting or extended release formulations are going to be reserved for patients whom immediate release opioids are effective, but they're going to require around-the-clock opioids for at least a couple of weeks. So we're thinking cancer pain, sickle cell disease, things like that, where those are going to really come into play. If we want to address acute pain, we want something that works quickly. So we're thinking more of our immediate release opioids and our IV opioids. Some of our long actings also include fentanyl patches, our buprenorphine pain products, things like methadone. And with those, there comes different clinical pearls we need to take into account. So I wanted to provide this as just a resource, and I'll hopefully get this sent out to you all. So as we think about converting our opioids or tracking total opioid use, you may hear a few acronyms. I have them listed here: oral morphine equivalent or morphine milligram equivalent. Those are really going to be terms that approximate a patient's opioid effects compared to oral morphine. So thinking a single dose comparison to what that would be in oral morphine. Where we have morphine equivalent daily dose, which is actually going to be a sum of all of the OMEs or all of the MMEs throughout the day. There's a ton of online calculators. I'd caution you guys all, and my advice would truly be to pick an equal analgesic table. I like Mary Lynn McPherson's 2018 table, and show the math and then check it with a friend or a colleague. These tables do have imperfections, but as you'll find when treating these patients, there's often a little bit of art to the science. So the table gets you kind of within safe parameters for treating the patient, but then ultimately patient-centered care, talking to your patients, looking at their home medications, determining, how long their pain might persist are going to be key in creating that regimen for them. These tables do have bidirectionality, so going from IV to PO or PO to IV may have an over-underestimation. And ultimately, the data that's used to create these tables is not going to be based upon opioid-tolerant patients or patients taking medications for opioid use disorder. They're going to be a little bit, those populations are a little bit outside the scope of the data used to make these tables. I put just a quick practice here. If you guys have some time or eating lunch, we have a few cases here. I'm going to run through them pretty quickly, but might be helpful to go through them on your own as well. But you'll see this patient, Miss Smith, she gets 10 milligrams of oxycodone every 4 hours. She takes about 5 doses a day. So doing the math here and doing a quick conversion, you'll find her NEDD is 62.5. Each 10 milligram dose would be about 12.5 OME or MME. So let's look at a basic example that requires some inpatient acute pain management. It's key first to meet these patients at their baseline opioid requirement, and then we're going to want to optimize that multimodal pain regimen and then think about temporarily increasing their opioid therapy. Our example focuses on a patient taking about 50 morphine equivalents per day. They're admitted after a fall, and it's certainly reasonable to increase this patient's IR opioids by about 25 to 50%. So this regimen of 10 milligrams every 6 hours may temporarily be increased to something like 15 milligrams every 6 hours or 10 milligrams every 4 hours. That would be going from about 50 MEDD to 75 MED. As highlighted, don't forget your non-opioid, your non-pharmacologic therapies, and anything that the patient maybe has found effective in the past. Okay, so here's much more complex, a couple more complex scenarios. So bear with me as we work through these, but you'll see some simple and similar principles that are applied to the continuation of either their long-term opioid or their medication for opioid use disorder. And that's what I'm trying to do here, is just highlight, some repetition and some simplicity to what might seem like a really overwhelming case. You'll see that all these patients have had acute pain from a motor vehicle collision. Scenario 1, the patient's taking OxyContin at home, around 150 MEDD for cancer pain. Scenario 2, they're taking Suboxone, 16 milligrams a day. And scenario 3, they're taking 150 milligrams of methadone per day. I do want to highlight that in scenario 1, we would continue that extended release long-acting opioid to prevent going into an opioid deficit or potentially experiencing withdrawal. But similarly, we would continue the Suboxone and the methadone as in scenarios 2 and 3. So really, whether it's a long-acting opioid that the patient is reliably taking, Suboxone or methadone, we're going to want to maintain that baseline amount of opioid in the patient. In scenario 1, we can consider temporarily increasing that IR opioid. We talked about in that first patient increasing by about 25 to 50%. In these more tolerant patients, we might think about a 50% or more increase. We should also think about increasing or adding on some IV opioid. And this might be for incidental pain, breakthrough pain, pain from dressing changes, mobility, things like that, since it is a severe pain event, the MVC. You'll see in scenario 2 that we can play on this shorter half-life that Suboxone has for pain. So Dr. South talked about, you might be able to split this dose into something like 8 milligrams BID. If pain is severe enough, or the patient maybe is exhibiting some breakthrough withdrawal symptoms, you could increase that dose to something like 8 milligrams TID to get better pain control. And we'll certainly talk about a few of the misconceptions surrounding these moves a bit later on in this presentation. As in scenario 1, we would also think about adding those opioid-tolerant doses of full agonist and maybe adding on IV opioids. In scenario 3, we would continue the methadone, add PO or IR agonists on top of it. We can consider splitting that dose as well. Although methadone it can be used for pain, it has quite a long half-life, and thus those pain effects won't quite take on effect as quick as utilizing something like PO, IR, oxycodone, or Dilaudid, or especially those IV opioids like IV morphine, Dilaudid, or oxycodone. But really, all these scenarios should be supported by multimodal analgesia. And then you'll see at the last bullet point for each of the scenarios, the consideration for an IV PCA. So this is a modality to what I like to call characterizing their analgesic need, which once we can do that, we can convert them to the proper PO or IV regimen. You can also consider additional adjuncts as shown below, and a few other helpful facts are listed there as well. So just as a nice reference guide for IV PCAs, if some of you guys are less familiar, they typically have a few components that can be programmed. For acute pain, we typically see a demand dose, or the dose they get when they hit the button, and a lockout period listed. And that's what's described in this chart here. Opioid-tolerant patients may require a higher demand dose than those listed for the opioid-naive patients. And with that, you might want to extend the lockout period a little bit longer. We'll see some examples of that with our scenarios we touched on just a minute ago. We have the continuous infusion option. That is typically reserved for somebody who is on a long-acting or extended-release opioid, and it's kind of a replacement for that. Those continuous infusions take a while to reach steady state. Therefore, we'd much rather use demand doses or things that work quicker to attack acute pain. If they're on PCA for a while or have extreme tolerance, maybe consider the continuous infusion. But most of the time, demand dose and the lockout are going to be what you really want to focus on. Well, let's go back to some of these scenarios. In scenario 1, we had that patient with the Oxycontin. So we're going to continue with that long-acting opioid if we can. We're going to increase the short-acting home oxycodone, and then think about adding an IV hydromorphone, maybe 1 milligram every 4 hours is needed. If you look at the PCA option for her, you'll see that we have a continuous rate there, and I say that replaces the extended release, which we talked about a little bit. In scenario 2, we can think about splitting and increasing that Suboxone, while a tolerant dose of oxycodone, plus some IV hydromorphone. If that's unsuccessful, we certainly have the potential to use the PCA. I want you to note here that the demand dose of 0.5 milligrams of Dilaudid is slightly higher than some of the doses for the opioid-naive patients. We also extended that lockout from maybe that 6 to 10 minute range to that 15-minute range, just to give the medication a little bit more time to clear. Once we capture the 24-hour usage from that PCA, we can use our opioid math, use our friendly table, check with a friend, show the work, and find a nice PO IV regimen that'll work for the patient. And then you'll see scenario 3 is pretty similar. We're going to continue the methadone. We might decide to split it from 150 daily to 50 Q8. We're going to give them tolerant doses of oxycodone and IV Dilaudid. You might want to trial a PCA, and from there we can make our moves. At the bottom of these slides, I always got to put in there, think about your non-opioids, your non-pharmacologic things. For severe pain instances like this, we might go a little bit deeper into our back pocket and find ketamine infusions, lidocaine infusions for pain, regional anesthesia, nerve blocks, epidurals, things like that. Now, throughout these next few slides, I want to just talk through a few considerations and tips to understanding some more complex pain scenarios. I want to orient you to this figure where we have a y-axis denoted to the number of mu opioid receptors occupied. So when a patient is on chronic opioids or MOUD with buprenorphine or methadone, they'll have a baseline amount of receptors occupied, which is signified by this blue line. We have the red line to the left of that, or really any amount under the blue line would create an opioid deficit. So to treat new acute pain, we must first occupy up to that blue line, and then we can think about treating on top of that to treat their acute pain. We did this in our examples by continuing home oxycodone or continuing their buprenorphine or methadone. So that's meeting that blue line. And then from there, we are able to, add oxycodone at tolerant doses, add IV Dilaudid, or add a PCA to enter this green area where we're meeting their tolerance and treating their pain. Of course, if you're using full agonist opioids, there is a point in which we surmount the green area and end up kind of at this last point, orange line, which would signify opioid intoxication or euphoria. So it's that sweet balance between, meeting their tolerance, treating their pain, but not overshooting it. Often, patients note that Suboxone blocks pain medicines. This graphic shows even at 32 milligrams of sublingual buprenorphine, which is quite a high dose, there are going to be open mu opioid receptors for full agonist opioids to bind. You might also hear patients say that naloxone blocks pain medicine, so they don't want to take it because it's a component of their Suboxone. It's worth noting that naloxone in Suboxone is actually inactive when taken sublingually. It's only activated if Suboxone is injected or used intranasally. I want to highlight this slide too about binding affinity, or what I like to call competitiveness for that mu opioid receptor or that mu opioid seat. Buprenorphine is always going to be kind of the leader in the clubhouse. So it's always going to want to, win the game of musical chairs and sit on that receptor. So that's why when we start abruptly at high doses and in the presence of full agonists, it can precipitate withdrawal. So if we have full agonists on board, we add a big dose of buprenorphine, it's going to kick all that agonist off, and you're going to have that precipitated withdrawal like Dr. South was talking about. That's why we use the microdosing or low-dose inductions when starting buprenorphine. However, when just treating a patient who has buprenorphine in their system, especially over 16 milligrams, you might want to consider using something like hydromorphone, which is actually the closest oral full opioid agonist we have to buprenorphine when we're thinking through this competitiveness. I want to talk a little bit about splitting buprenorphine. This will provide a greater time over the pain threshold, since the half-life of our agonist MOUD products range from like 6 to 12 hours. So you'll see here, this top graph is showing just giving that once daily dose, where for a little bit of time, they're over the pain threshold. For the full daily dose, they're going to be over the OUD threshold to protect them from cravings and withdrawal. However, if we split that, we're always going to be over the OUD threshold, and we're going to spend more time over the pain threshold, which is going to help our patient. I included this summary slide of methadone versus buprenorphine, just highlighting methadone for OUD can only be dispensed from an OTP, whereas buprenorphine may be prescribed by anyone with a DEA license. Just recall that we have some different buprenorphine products for pain, which differ in dosing, normally in micrograms versus our OUD products are in milligrams. But I was hoping just to include this as a reference for you all. I have a slide here, which should be helpful for you guys to look over as well. Just talks about buprenorphine being dosed in milligrams, which is typically for OUD. While when dosed in micrograms for pain, there are conversions that exist. Some examples are listed here. The kind of blue and red graph is from an article from Justin Colgren with a K. I find that a helpful article when thinking about starting a patient on a B-trans patch or Belbuca. I do want to make note that around 16 milligrams of buprenorphine sublingual is actually around 400 to 480 morphine equivalent daily dose. So quite a bit of opioid. It's a little bit different because that's a partial agonist compared to our full agonist, but still it's quite a bit of opioid, which is why we need to, potentially treat these patients a little bit differently than our opioid naive folks. I have some key takeaways listed here. So calculating the NMEs, OMEs, MEDD is best done by using a validated equal analgesic table. Show your work, check it with a friend or a partner. When titrating opioids, accounting for acute pain, you may want to use that 25 to 50% as a benchmark for our less tolerant patients who still have some opioid, up to around 50 to 100% for some of our more tolerant patients, or maybe a patient who's on MOUD. If you're really not sure, think about that IV PCA as an intervention for that first 12 or 24 hours to characterize their analgesic requirement. Similar to continuing home opioids, continuing MOUD prevents an opioid deficit. You're going to get much further with treating a person's pain if you can meet that opioid deficit. And then recall some of these pearls regarding buprenorphine. It can be split dosed for pain, potentially increased. There will be an open mu-opioid receptor for full agonist to bind, no matter kind of how high that buprenorphine dose is. The naloxone component does not block full opioid agonist effects. Hydromorphone definitely is going to be more competitive for that receptor in the presence of buprenorphine. There are oral hydromorphone products. Most hospitals have them on formulary. They come in multiples of 2, so you'll see 2 milligrams or 4 milligrams, 6 or 8 milligrams of PO Dilaudid. So those do exist, so don't forget about those when treating your patients. They might say, hey, oxycodone is ineffective for me, and you might say, hey, try this PO Dilaudid at an equal dose, and they might find a little bit more benefit. Awesome. And that is the conclusion of my piece. I think we're going to have some time, potentially a couple minutes, for housekeeping or some questions. Thanks all.
That's great. Thank you guys so much for that enlightening and thought-provoking discussion. I definitely learned a lot myself from listening. And before everyone leaves, feel free to use the Q&A chat. We may have time for 1 or 2 questions, but I just wanted to remind you that at Doctors for America, we believe that education is important, but so is action. So after tonight's session, please consider taking one of the following advocacy actions. 1, potentially even taking additional CME courses and managing patients with substance use disorders. Consider writing an op-ed or sharing your experience with patients who may have been from one of these marginalized groups we talked about. Share this presentation, the recording, with your friends and colleagues so we can have more physicians providing this excellent care, and invite others to join DFA if that's something that you're interested in. Please watch out for additional opportunities to provide input on policy, and for those that are paid sustaining members, we do have that CME credit available that's in the chat. And if you enjoyed this Advocacy Grand Rounds, please consider supporting Doctors for America's work with a financial gift, and the link to donate will also be put in the chat. Thank you guys again for that. Are there any questions before we let everyone get back to their evening?
I had a question. So I found myself having a really hard time convincing like nurses and the floors to continue like high doses of opioids, particularly for like opioid tolerant patients. Does your institution like have protocols for this, or like how do you recommend that we are able to, do what is in fact evidence-based medicine in sort of a setting where people are like very uncomfortable with the safety of something that is actually like safer than not prescribing what some people might think are large doses of opioids, because we're preventing people from then, losing their tolerance and overdosing when they leave?
What I do is like education and then frequent follow-up. So just educating nurses or other physicians and providers on why we give higher doses, and then frequently following up, especially, with nurses or whatever. If they really don't want to give it, I say, great, we'll try a lower dose first, see how it goes. And, the patient is on the monitor. We will see what's going to happen. And then we can give a higher dose afterwards and, give a second dose and then just see the patient again, check in with the nurse again. It's kind of what I do.
Yeah, and I think those are great concepts there. I would also say that sometimes we just would put in the admin instructions, hold for, a respiratory rate less than 12 or less, a systolic blood pressure less than 90, just to have that extra layer of, I guess, protection for the nurse, when we might know as providers or clinicians that the dose we give probably won't have quite that effect, but just gives kind of a good communication for everybody to have something to monitor. We also have some initiatives like in our PACU order set. We've just updated it where the anesthesiologist or CRNA will be able to click if there's an opioid naive patient or opioid tolerant patient, and then the defaulted doses, are a little bit higher for that tolerant patient. And so when you kind of have it built into order sets and things like that, I feel like it's a little bit more widely accepted, but still a question that is just we're going to face, I think, until kind of culture shift and things like that.
All right. Any other last minute questions? We are at our time. I don't see anything coming into the Q&A chat. Sounds great. Well, thank you guys so much for your time. I think you guys covered things so great that we didn't have to have any additional questions on that. I do really appreciate it. I think that we can all take this forward and provide better care for our patients who may, as we talked about, have substance use disorders or just on chronic opioids as well, and making sure that we're not causing more harm than we are good. All right. Well, with that note, thank you all for coming to our advocacy grand rounds. I hope you have a great rest of your evening.